Thank you, Rehan. Уважаемые коллеги, уважаемые коллеги, мы немножко выбиваемся из графика, поэтому продумывайте заранее вопросы, чтобы четко их формулировать, тогда получим более четкие ответы. Все, спасибо.
Okay, so thanks again to Sergei Vladimirovich and the organizing committee for having me here. It's my fourth time in Russia in 12 months, so you can see I've become very fond of this country and especially the people and the professionalism of endoscopists in this country. So as Rehan already lined out, quality, especially in diagnostics, has become very important also for upper GI endoscopy. So I will be mostly focusing on the therapeutic part, as Rehan. As for endoscopic therapy of early cancer, you know that in the past endoscopy was purely diagnostic, and therapy of gastric cancer, esophageal cancer was all surgical. So in the mid 70s in Japan, because of the high rate of early cancer, especially gastric cancer, endoscopic methods like endoscopic mucosal resections were developed in order to offer therapeutic options and curative approaches to endoscopy. And some years later, the technology we're still using today have been developed, namely CAP EMR and ligation EMR. And as I'm going to show you, they're very simple and effective methods in order to resect small lesions. And with small lesions, I mean lesions with a diameter of less than 2 centimeters. Then, a little bit later again, in the late 1990s, early 2000s, endoscopic submucosal dissection was developed because, as you've just seen, the main limitation of EMR is size. And with ESD, you have basically no limitations of size. You can resect any kind of lesion as long as it fits into the criteria for endoscopic resection. And if we look at it again, as I've just told you, initially it was developed as a treatment for early gastric cancer. But right now, EMR and ESD can be used anywhere in the GI tract. We use it in the esophagus, we use it in the stomach, the duodenum, and of course the colon. The main drawback of endoscopic mucosal resection is the difficulty in resecting larger lesions en bloc. And if you're dealing with cancer, we have to compete with surgeons. And surgeons always tell us that you have to resect a lesion in one piece and not in many pieces, so the pathologist can actually assess whether you did a complete resection or not. And with ESD, it has become possible to resect also larger lesions, but EMR still today has a role, especially in the esophagus for Barrett's esophagus, in order to resect intramucosal cancer up to 15-20 millimeters. So what's our play field? If you look at this slide of the esophagus, you see that we have four mucosal layers and then the 3 submucosal layers. And the play field for the endoscopist, be it squamous cell cancer or Barrett's carcinoma, is always the mucosal layer. There's a borderline situation with SM1 infiltration, but usually we try to stick to resection of lesions in the mucosal layer. And the background, and I'm showing you here Barrett's cancer as an example, is that there's almost no risk of lymph node involvement in mucosal cancer. So surgery would definitely be an overtreatment in those situations where you can have a very minimal invasive, very safe and fairly easy procedure in order to cure the patient from mucosal cancer. It changes drastically when you have submucosal infiltration. You can see the data here. Once you reach the tumor reaches SM1, the lymph node risk goes up to 13% and more. So that's the end of the line for us endoscopists. So if there are any surgeons in the room, they don't have to be afraid. We don't take away anything from them. They still have a lot of indications for their treatment. And as you can see here in this slide, if we have high-grade dysplasia or carcinoma in situ, we have either an ablationist therapy, and we're going to talk about this in a couple of minutes, or endoscopic mucosal resection. In case of intramucosal cancer, the treatment of choice nowadays should be EMR for small lesions or ESD for larger lesions, larger than 2 centimeters. And everything that goes beyond that is either a candidate for esophagectomy or a combination of other means of therapy like radiotherapy, chemotherapy, and or surgery. So how do we perform mucosal resection? You probably know this, all this has been around for many years, this kind of technique. Currently we're using either cap EMR or ligation EMR, and they are mostly used today in order to treat focal lesions in Barrett's esophagus. And the indications are either lower high-grade dysplasia or intramucosal adenocarcinoma. And in Barrett's esophagus, those lesions are usually small, so there is rarely need to do an ESD for Barrett's esophagus, and so EMR is mostly sufficient. The main advantage of EMR over ESD that it is a very safe procedure, complications occur rarely, and it's of course a very fast procedure. You don't need as much time as you need for ESD. And of course EMR is commonly used in Europe because we have other indications than the Japanese. We have a lot of Barrett's esophagus, especially in countries like the United Kingdom, Northern Europe, where we see those lesions quite frequently, and therefore we have quite a good experience in Europe with this kind of method. The most simple method would be injection and simple snare resection, which is usually not sufficient for Barrett's esophagus, so that's why we perform either EMR-C or EMR-L. And I'm going to show you in 2 cartoons how those methods work. On the left you have the Olympus cap. It's usually an oblique cap, and you inject. You have to do a submucosal injection, and then you place a special crescent snare into the rim of the cap, and then you suck the lesion inside the cap and perform basically a polypectomy. As you can see, this takes just seconds, and you can do piecemeal resection of larger lesions, but as I've told you, we try to do en-bloc resection whenever it's possible. The rubber band ligation is even simpler. You just need a kit from either Cook or Boston, and then you aspirate the lesion. There is no need for submucosal injection because of the elasticity of the rubber band. You deploy the rubber band, and then you snare the lesion under the rubber band, and that's it. So 2 very simple lesions, procedures for fairly common lesions in Europe. So again, to wrap up the different techniques, here you can see the Olympus kit. You have mostly the oblique cap with the crescent snare. You're using it. It's a specialty snare. It's a little bit more fragile because it's rather thin. You have to pass it through the working channel. And then you inject before, usually with saline and a little bit of dye, and then you just resect and snare the lesions, and that's it. Just to show you how it looks in real life, you see a nodular lesion, and 2A lesions are most frequently either high-grade dysplasia or cancer, and this is at the 1 o'clock position. You can see it here on the left-hand side. We're using iScan to get a better idea what it is. And you can clearly see the change in color between non-dysplastic Barrett's esophagus and this slightly elevated area with cancer. And on the right-hand side, you can see how the EMR is performed. We're placing the snare into the cap, and then we move up to the lesion, suck it into the cap, and then just perform the simple snare resection. So that's EMR-C, and I'm going to show you how the procedure ends. So we're now on top of the lesion on the left-hand screen part, and we aspirate it. We close the snare, we push the snare out of the cap in order to make sure we got it right. And on the right-hand side, you can see this was done in a piecemeal fashion. This was a large area resected, so we did 3 cuts, and then of course the patient moves on to a radiofrequency ablation. That's the result you get. And it's always good, and Rehan already mentioned it, you have to give the most accurate information possible to your pathologist in order to get reliable reports. Actually, one of the oldest kits on the market is the Cook duet system. It's nothing but their usual ligation device, the 6-shooter, and you have a dedicated 5 French snare which you can pass through the working channel, even with the ligation kit inside too.
Перевода нет.
Obviously, I said something wrong.
А как кондиционер, кстати, не жарко? Включить, да? Но если будет холодно, вы скажите мне.
Okay, so the technique is fairly simple. Usually you rotate the lesion in the 12 o'clock position, you suck it into the cap, you deploy the rubber band, and you don't need submucosal injection because of the elasticity of the rubber band. The mucosal layer slips out of the rubber band and then you can safely resect. There is a more recent development from Boston Scientific. It's the captivated EMR, which is a dedicated ligation set, which works in the exact same fashion as the duet system, and whatever you use, it's up to your choice. So we have different techniques. Is there any difference when it comes to results? Well, actually, not really, nothing significant to my taste. There is a comparison study between a cap EMR and ligation EMR, and in this study the ligation was faster than than cap EMR, although 50 minutes for an EMR, well, I don't know what they were doing all the time. Costs seem to be a little bit lower for the duet system, at least in this study, and there was not really a big difference in the size. But as you can see here, this pretty much 2 centimeters is the end of the line when it comes to en bloc resection. There was no difference between for complication rates, and at least from this study, it seems that the rubber band is slightly superior. I've started my career with cap EMR and I stick to it, so it's just a personal preference. So as I've told you, the main limitations of EMR is size. And whenever you have lesions which warrant an en bloc resection, and I would count all cases of squamous cell cancer into it, I wouldn't perform an EMR, I would do an ESD. Another problem with EMR is the so-called non-lifting sign. So when you start injecting, and maybe because of prior biopsies or because of infiltration, you can't separate the mucosal layer from the muscular layer. You find a non-lifting sign. Some cases can be resolved with ESD, but usually EMR can't be performed. And of course, once you do a piecemeal resection, you have to expect higher rates of local recurrence, so you have to do some additional treatment in order to bring that down, for example, like the APC I did during live endoscopy yesterday. Back in the old days, when we didn't have radiofrequency ablation or cryotherapy, we always wanted to get a complete or achieve a complete resection of Barrett's esophagus, because we know that in case of dysplasia or carcinoma, we have a fairly high rate of metachromius lesions at around a third of the patients. So we want to get rid of all Barrett's esophagus. And in the past, circumferential resection with EMR was the method of choice because there was no thermoablation available. As you can see here, the main problem with a circumferential resection is stricture formation. So nowadays, I wouldn't recommend to do a circumferential resection in Barrett's esophagus. I would refer the patient to a radiofrequency ablation or cryotherapy after resection of all focal lesions. As for complications, I already told you it's a safe procedure. There is bleeding, and as you can see here in the video clip, it looks dramatic, but and it occurs frequently. You have to expect bleeding in up to 30% of all EMRs. but this is nothing that scares us. We can treat this easily endoscopically by either treating it with clips or with APC or injection. So this is more a nuisance than a complication. Perforation has been described in somewhere between 0 and 5% after circumferential EMR, so you don't have to fear it in focal resection of areas, and strictures only occurs in circumferential EMR. So to wrap it up, it is a very safe procedure. I've already mentioned radiofrequency ablation, and we use it actually only after resection of focal lesions. Some people find biopsy results with dysplasia. In my experience, there is nothing like an invisible dysplasia. If you have dysplasia in your biopsy, you haven't looked good enough. You have to be really careful. You have to use chromoendoscopy. You have to use acetic acid. You have to use your filter technology, be it iScan, be it FICE, be it BLI, be it NBI. There is nothing like an invisible dysplasia. You have usually a changing color. You have maybe a slightly elevated area, and then you should resect it. The residual Barrett's should be destroyed thermically, and the most commonly used method today is radiofrequency ablations. You have a variety of catheters depending on the extension of the Barrett's esophagus, and you have the balloon for circumferential, or you have those focal catheters like you can see here. The advantage of radiofrequency ablation is that's again a very simple and safe method. It just affects the uppermost layer of the esophagus, the mucosa, and leaves the underlying tissue mostly unharmed, although strictures do occur after circumferential burning. And the new kid on the block is cryotherapy, and let's see if it will take off in the future. With cryotherapy, we don't use heat, but liquid nitrogen, and with liquid nitrogen we just freeze the Barrett's esophagus. We can also use alternative methods like hybrid APC, where you use the ERV water jet to inject with high pressure into the submucosal layer and then perform APC for thermal destruction. But of course, this is only for small areas of Barrett's esophagus. As for the results for cryotherapy, you can see them here. After the initial treatment, almost all patients were free of high-grade dysplasia, and 90% were free of dysplasia, and in 60% all Barrett's was eradicated. And after 5 years, results were still good. No high-grade dysplasia in 93%, no dysplasia in 88%, and 75% didn't show any Barrett's. So there is a yearly recurrence of intestinal metaplasia even after thermal destruction. You have to continue with surveillance in those patients, but you can reduce the intervals. But in my conclusion, dysplasia and cancer should be neither grilled or frozen, but resected. But in combination with resection, you should any thermal method in order to get rid of the residual Barrett's mucosa. So, coming to the conclusions for Barrett's esophagus, you can see it here. In case you have a visible lesion, be it high-grade dysplasia or low-grade dysplasia, and it has been confirmed by a reference pathologist, because especially in low-grade dysplasia, we have a lot of issues getting a correct diagnosis. You should resect it, in most cases with EMR, and then do a complete eradication of the Barrett's esophagus. As for submucosal dissection, the image changes a little bit, and here you can see the expanded criteria by Gotoda. As you can see in dark blue, the guideline criteria for EMR are lesions less than 2 centimeters, which are not ulcerated, and then you have the area for ESD. So if you have a non-ulcerated lesion, you have no size limit whatsoever for ESD, and I'll show you some cases. If there's ulceration, and this refers mostly to gastric cancer, of course, you have a size limit of 3 centimeters, and if there's submucosal infiltration, again, you have a size limit of 3 centimeters, but that doesn't go for squamous cell cancer, but for gastric cancer as well. So, as Rehan already showed you nicely, esophageal squamous cell cancer is extremely difficult to spot. So you need some additional technique or technology in order to make it visible. But first you have to know what you're looking for. And if you look on the left-hand side of the screen, you have you have a complete flat area in the upper part of the esophagus between 11 and 5 o'clock, which has a slight change in color. And that should make you aware that there might be something wrong, together with the history of the patient. As Rehan mentioned, if he has a history of squamous cell cancer in the oropharynx or in the lungs, or if he's a heavy smoker or alcoholism is a problem, be aware. And then you can use your endoscopy, like with Lugol's, and you can nicely see that the lesion becomes visible because it doesn't pick up the Lugol's. And what you also notice that squamous cell cancer is always much bigger than you initially think. So be careful with your assessment, and then do your endoscopy and take your time. When we do ESD, and this is the same patient as we've before, and I'm going to guide you through the ESD procedure here, you always have to place markers outside the lesion in order to make sure you have achieved a complete resection. There's nothing worse than doing a 3-hour ESD in the esophagus and have an incomplete resection at the end of the day. So I usually use APC in order to mark the outer margins of the lesion, and then I make sure I do my resection outside my markers. So all the markers have to be on the resected specimen. The next step is submucosal injection, and in this case I'm using the ERB hybrid knife, which means that we have to rely on saline and a little bit of dye. You can, if you don't use the high pressure pump, you can also use hyaluronic acid or glycerol or whatever to have a long-lasting effect with the submucosal injection. But a hybrid knife from whatever company usually is very useful because you don't have to swap instruments between cutting and injecting. Then the next step is incision. So usually we perform a circumferential incision. In this case, we're using an IT nano knife from Olympus, and we cut around the markers, and then the specimen starts to resect, which gives us an easier access into the submucosal space where we can actually perform the endoscopic submucosal dissection. In the esophagus, of course, insulated tips are useful because you reduce the risk of perforation, and so especially when you start this kind of procedure, we recommend using an insulated tip knife at the beginning. Then, at this stage, you mount a cap in order to get a better access into the submucosal layer, and under direct vision and visual control, you can dissect the fibers, as you can see here. As I'm not a very patient person, I don't like insulated knives, so I'm using a hook knife here. And all visible vessels should be treated before they start bleeding in order to reduce procedure time, in order to keep your operation field clear. In that case, you can use a hemostatic device like the hemostat from Pantex, which is not only cheaper than the coag rasper, but also potentially safer because it's bipolar, or you're using the coag rasper. And never forget, the goal of ESD always is complete en-bloc resection. And this is the result of the 2 different ESDs in the esophagus. On the left-hand side is the case we just did together. So this was a fairly large tumor with almost circumferential growth we resected. And on the right-hand side, another case of an early squamous cell cancer, and in this case, this is the specimen. As you can see, this is an 8-centimeter cancer, which we resected en bloc in one piece, and of course completely. And we've made sure that the patient didn't need esophagectomy. So you can see this minimal invasive approach makes a huge difference to the patient, because he went home after 2 days, and you never walk home after 2 days after esophagectomy. Of course, there are issues and there are problems. And one problem, of course, are strictures. And this is the patient you've seen on the left-hand side in the slide before. He, after 3 weeks after ESD, he was on a holiday and he had issues swallowing. So he came back to us, and as you can see, because of the almost circumferential resection, he developed a stricture. So strictures and dysphagia are one of the limiting factors of extensive ESD. But we have remedies for that. So we can either dilate the patient, we can use local steroid therapy or systemic steroid therapy. And many different approaches have been studied. And again, this is the same patient from before. And my preferred approach has become to do a dilation and then to put the patient onto systemic steroids. And with that kind of approach, at least in our personal experience, we get good results and usually have to do only 1 or 2 dilatations and the patients are doing fine. There's one thing you must not forget. Whenever you choose a patient for endoscopic resection, you have to make sure he is willing to come back for follow-up procedures. As we preserve the organ, of course, metachromius lesions can develop because the risk factors don't go away, especially in squamous cell cancer. So, if with every other cancer resection, follow-up is necessary, and usually after ESD, our first follow-up is performed 3 to 4 months, and then after another 6 months, and then on a yearly basis, in order to make sure we don't miss anything. And we apply the same conditions like we did for the first time. So we take our time, we do deep sedation, we use chroma endoscopy, we use a high resolution or zoom endoscope in order to make sure not to miss any lesions. And in case the patient develops a metachromius lesions, of course, we can usually resect it. ESD can also be used for Barrett's esophagus, and I'm going to show you some video clips. We had this patient with this fairly large nodule at the junction. The biopsies were positive for cancer, and because of the location of the lesion and because it wasn't quite clear if it's a Barrett's or a gastric cancer, I decided to do an ESD. So we did some cases of Barrett's esophagus with ESD. As you can see, you have to work in retroflexion most of the time. You have to expect quite some bleeding in this area, and it's a fairly complex procedure. But as you can see, it's feasible. Of course, I wouldn't recommend to start your first ESD with a Barrett's esophagus. You can see it's looking a little bit messy. You have a lot of muscular fibers. It looks like a poem. Basically, that's what you're actually doing, but at the end, you can achieve good results. Initial data, however, for ESD for Barrett's was not so good. But fortunately, that was only this German study who didn't yield any excellent results, and later on we found that the other studies that couldn't confirm those bad results. But in this study, which was one of the first one actually, also with a new technique back then with the water jet, only 10 out of 26% were completely resected, and that doesn't reflect my personal experience. So I think there is a learning curve, of course, you have to expect. So it works. It is a good approach for very complicated Barrett's situation, but of course it needs the hand of an expert. And this is the results, of course, comparing ESD versus EMR, and the results are quite clear. This is a meta-analysis published a couple of years ago in the World Journal of Gastroenterology, and as you can see, of course, we have a much higher rate of curative resection with ESD. It is definitely more time-consuming for a very, I told you need 15 minutes or so for an EMR. You don't do an ESD of a larger lesion in 15 minutes, so it's definitely something you have to plan and schedule. Obviously, also the risk of perforation is higher for ESD. I've showed you that EMR basically has a very low risk of perforation, and with ESD, where you have where you're working freehand without any guidance, the risk is definitely a little bit higher. Interestingly, there is no different when it comes to stricture formation, so strictures do occur as often after EMR as they do after ESD. And interestingly, again, bleeding seems to be a little bit more frequent after EMR, but also that can be explained because you're treating visible vessels during ESD, unlike EMR, where you have an uncontrolled cut with the snare. With ESD, you operate under direct vision, and you have all the time in order to coagulate visible vessels. So, coming to my conclusions, to save a little bit of time we've lost during the day, EMR is in the esophagus is really easy to master, and it's generally considered to be a very safe procedure. As I've shown you, I tried to show you, there is almost no risk of perforation. However, be prepared for bleeding. Regardless of the technique used, the indications for EMR are small dysplastic areas or small mucosal cancers with a diameter up to 2 centimeters. ESD definitely is a way more complex procedure, but it has a much higher rate of curative resection and is the method of choice for anything larger than 2 centimeters. And in my personal opinion, is the only treatment option for endoscopic resection in squamous cell cancer. As I've shown you, squamous cell cancer is almost ever is bigger than you expected from the white light picture. So take your time, do a careful inspection, do your endoscopy, and then choose the right method. ESD needs considerably more skill and more expertise. The last doctor I've trained, I went to another place in another hospital. We did cases every second month, and after 3 years he was fit and confident to do his first ESD alone without any intervention from myself. So if you want to learn ESD, go to a Japanese center where they have large experience. Find someone who teaches you in your local unit, and be patient. Be patient. It is a complex method, but it's worthwhile learning. And of course, not everybody has to learn it. We have few cases, so it's much better than we have a handful of experts and expert centers who provide high quality service than many people doing 2 or 3 cases a year. And that's it. And with some impressions, what you can actually do with ESD, and which is endoscopic surgery, I'd like to thank you again for the invitation. Thank you for your attention, and I'm open for your questions.
Mr. Hafner, thank you very much. And maybe some questions, please. Пожалуйста, вопрос.
Большое спасибо за очень интересный доклад. Существуют литературные данные, по которым при радиочастотной абляции менее чем в 1% случаев, но все-таки встречаются очаги захороненных базов. Вопрос, встречались ли у вас в практике такие случаи? Какая была тактика? Как вообще вы относитесь к понятию захороненного база?
I've seen one case of submucosal cancer or subsquamous. That's why I said you still have to continue with follow-up in those patients. And they are hard to spot. Those submucosal or subsquamous cancers are difficult to spot. I missed it the first time. But what I do, I record on video every single Barrett's esophagus, also the diagnostic procedure. And then I reviewed the case. I scoped the patient 6 months before he came back with the cancer. And I found a dark spot on the squamous cell mucosa. There was nothing there but the change in color, because underneath was the cancer. In this case, it was very easy to treat. We performed another mucosal resection, and which was curative. It was an R0 resection, and the patient is still in our follow-up.
Если можно вопрос. В тех случаях, когда вы провели радиочастотную абляцию, исследователи указывают, что бывает очень тяжело в дальнейшем выполнить follow-up endoscopy и понять, где таргет, взять биопсию. Каковы были бы ваши tips and tricks?
Well, I mean, what I would recommend is, in any case of Barrett's esophagus, to always use acetic acid. Whatever scope you have, whatever generation of scope you have, go to the supermarket, buy some vinegar. They're cheap. Usually we use 3% acetic acid, but if you use undiluted vinegar, all kinds of dysplasias start to bleed. So with 6% acetic acid, which is vinegar, usually if there is any dysplasia, you see not only the change in color which you're expecting, but also some bleeding. So always do a careful inspection, take your time. Use endoscopy all the time. use the best endoscope you have in your unit. So if you have a lot of standard definition or even fiberglass scopes and one HD scopes, only do Barrett's with HD scope. And as for those recurrences of Barrett's after RFA, they can be, as I've told you, below the squamous cell epithelium. So, of course, you don't see Barrett's mucosa there, but you might see color changes. So, be aware, look for color changes, and not only for Barrett's mucosa, which of course you recognize easily.
Еще есть вопросы? Пожалуйста.
Скажите, пожалуйста, вы говорили о послеоперационных осложнениях, структурах и говорили о хорошей терапии, волне реабилитации и системном применении стероидов. Вот. Можно узнать, в каких дозировках, как долго и как относитесь к местному введению стероидных препаратов?
Yeah, well, there are studies for both. So first, I prefer to use bougies. It's cheaper. I have tactile feedback, and that's why I wouldn't use a balloon routinely for strictures after ESD. Second, we tried triamcinolone injection with local steroids, but in my experience, when I treat the patients with oral steroids for, let's say, in some it's like Crohn's disease for 2 months. So we start with 1 milligram per kilogram body weight, and then we taper every week. And with this kind of approach, usually after the first dilation, the patient stays stricture-free. But there are many studies, and many things have been tried. I mean, there's also tissue transplantation has been tried. There are all kinds of approaches to this. But I think local steroids are not as effective. That's my personal experience and my opinion. And systemic steroids are very easy to do, and they seem to be effective.
Вы довольны, да? Еще один вопрос, и на этом мы заканчиваем дискуссию, потому что мы очень выбиваемся по времени. Последний вопрос.
Большое спасибо за интересный доклад. Скажите, пожалуйста, вы пользуетесь бужами и берете одного размера, и если одного размера, то какого, если это последовательность, то какого? Одного размера, до какого?
Usually I stick to the old rule of 3, although we have no evidence that supports this rule of 3, so I used 3 ascending diameters. And the initial diameter depends on the stricture. So if it's a very tight stricture, I might start with 7 millimeters and then do 9/11, or start with 9 and now do 9/11, 13. So it depends on the initial size, but usually I stick to the rule of 3.
One time.
Yeah, if the patient responds well to one-time dilatation, and I've shown you the video after this, then one time is enough. So the stricture I've shown you, I think we did a total of 3 dilatations, 2 without steroids, and the last one with steroids, and after the last one he was fine.
Ну, то есть одновременно 3 последовательно бужа.
Yes, in one session, and of course the number of sessions depends on the symptoms of the patient.
Thank you. Thank you very much, Mr. Hafner, and we'll continue our session. Please, доктор Смирнов со своим докладом «Диагностика и удаление раннего рака пищевода».